making a diagnosis for our patients. Because some of our patients in Malaysia, they have took 4.5 years to know the diagnosis. So here, because the scenarios, everything is given to you, but you know that how long it takes for patients to come to the diagnosis. This is very important for us to have a diagnostic network for the region. I think my last comment after this, I'll pass to my colleague. All of you have mentioned about the funding, right? About the money. And I cannot promise here in front of you because I have a Malaysian delegates too, from Tong, Nadia. I cannot promise how much government can provide funding. But for Malaysia, government has consistently provided 25 million Malaysian ringgit a year. But that much of money only benefited 60 patients. You see how expensive is the drugs, though it is only 5% of patients need treatment, but the cost very, very high. That's why we have to talk about the pool procurements of drugs, especially on the ERT. So we have to work together with the pharma, we have to involve in the clinical trial, we have to involve in R&D, then only we can talk and negotiate with the pharma about the drugs. What I'm going to suggest here is that we need to have a full procurement of the drug for the region. Some states, some country, the member states need to take a lead in this. If it is not, I think Malaysia, Philippines, Thailand and Indonesia will have a different cost of drugs. And Australia as well. So we need to take lead. Some member countries need to take lead on the full procurement of the drug. That's my first comment. I pass to my colleagues.
Thank you.
Tough time? Yes. Thank you.
Thank you, and again, congratulations.
I mean, so the Ministry of Health has to talk with the numbers also to the Ministry of Finance. So I think it will be also good to show the data with numbers. And although without discrediting the life is the people is the life itself, we cannot undermine that. But on the other hand, we have to understand that in terms of the funding, also the government has KPI to reach. So it has to be like how the Minister of Health will think about what you already advocate and make it into, like Dr. said, the pillar that they also have to reach. And also, it is also important to think what is the lowest hanging fruit. I also very appreciate those groups that already make their plan into phases, because usually the government maybe will think, okay, what is the lowest hanging fruit that you can show us that this is actually actionable, and for after that you can build on top of that. And why is also important because we also talk about the local government and also the central government. The local government will need some kind of lead narration to actually to buy in and to support you, so they also can have a good image in front of the public that, oh, we actually can do this because of this local government. So we will elect them another second session, like that. And also for the central government, again about the KPIs, because we also have to think and advocate to the Ministry of Finance, and also maybe for the in the longer term, like organization of planning in longer plan. So it is also it is important to bear that in mind when you present or advocate your implementation program. Thank you.
Good afternoon. I love this afternoon activity. I shortly attend the group number 3. They have many brainstorm. The facilitator can ask is the outlook of team, can each the problem. I think is regularly similar with the problem with each group. I cannot remember it's 10 of these, but I was totally agree with them. And the group number 3 and number 9 was a sample with the XDP disease. It's very rare, outer land. It's very difficult for decision for policy because the financial is a major condition. I would like to share with a bit like this. In the group number 3, they say for how to increase the R&D, how to increase the awareness, education, and accessibility to diagnosis and treatment. They say for a lack of technology and limit for genetic physician also required for the finance support. And collaboration, of course, with the sector of governments, like bottom-up, try to settle the action plan and negotiation to the 5 plan. I would like to add a bit more information for the outer rare disease, like maybe due to collaboration with international for, like I said, the patient to the treat or to the other country, they have more advanced technology or like doctor, she says, for core programs in the country, which they have excellence because this is
The government. And Group 5 said that if we invest on preventing early detection of rare diseases, perhaps you would be able to prevent the NCDs. And that would be a good example of what is it in it for the government. Because I would like to link that to the priorities of the government as well. When we talk to the government, maybe it is also favorable if we pause minor pivots onto the priorities of the government. And what I wanted to say here is we should be able to leverage on the priorities of the government. Say, for example, yesterday our dear Secretary of Health mentioned that the priority for primary care is ensuring that we will be opening up intermediary centers where we call bukas or bagong urgent care and ambulatory service. So our plans should be able to reflect as well how we would be able to leverage on those current initiatives of the government so that the government will have only minor pivots around the priorities on financing. And when we say financing, I also waited for Group 4 who ably pointed out that I have 55 seconds left.
Next week we have a second round. This is just
for Group 4.
We have a second round.
Who ably pointed out, Doctora, that maybe they will be able to identify as well other agencies that could help in the programs on addressing rare diseases, and not mainly on the health department. And it is very, it is also, I would like to also suggest that our advocacy groups should also be able to navigate within the health system and have good knowledge of who does what in the health system. Because in the health system, we are surrounded by the social services sector as well. And who knows, we have duplicating programs in terms of providing social support to the people living with rare diseases. So I'd like to thank you for your attention and pass it on.
Thank you so much. So I think I want to build on top of that. Again, I want to also address the financing because it's also a very critical
has led to quite a number of shortcomings, a lot of delays. Many of the times, the follow-up to the newborn screening is not there. For example, once you have diagnosed a patient and a baby, what do you do, right? You need to give the proper treatment, perhaps give the special milk formula. You also need to provide genetic counseling to the family, and also what happens to the next child that they plan to have. So all the systems should be integrated because they are all part of the entire system, the universal healthcare system.
Great. Dr. Huidu, would you like to comment on this as well?
I think in my country, the most challenges why when want to implement in newborn screening that is how to provide a comprehensive newborn screening services not only the test, because in our country right now we have a policy for newborn screening for several diseases, and also have the funding from social insurance, especially for the rural area for the poverty. But from the percentage children compromised the newborn screening will be low, because one of that, because the patients, the family, they don't have enough information, especially the pre-test information, so they don't understand exactly the benefit of the testing of the workflow for newborn screening. And
family. I would like to pose these questions to Dr. N.K. Tong in Malaysia.
Thank you very much. Now, newborn screening program has been around for a long time. The issue here is trying to decide whether this is a hospital-based program or a public health program. My take on this is...
It's a great honor for you today to be here at the Asia Pacific Alliance of Rare Diseases, APARDO Conference 2024. We are here for a shared purpose, to make rare diseases a clear priority in universal health coverage or UHC, both in the Philippines and across Asia and the Pacific region. Today,
failure information located right, and we know that there are some okay, so now what we need to do is first define the problem. We need to discuss all of them, and what we hope to have and to provide a scheme dedicated to rare disease drug with probably two different buckets depending if the drug is a chemical drug or if the drug is a bio drug, because all the scheme related to supply, related to production is completely different. So we are actually scoping if we can provide this type of scheme. We also truly believe that that would not be possible to find one system which fit for every country. I think that Durant showed that this morning there is plenty of different aspects, cultural, socio-economic, etc. And I think that probably what we will try to do, and this is something that we have started the discussion with WHO, is to see what kind of tool we can propose. And country could have the opportunity to pick and choose what is the most adapted system for its own consideration. So this is what we try to do actually, scoping and work on that, and we hope to be able to have some concrete things to propose for next May, beginning of the discussion of the Global Action Plan.
Well, thank you for sharing that. Working with RDI, Rare Disease International, and WHO on how we can work on the pricing, and then looking at two models that's working for the rest of the world, the GAVI model and the UNICEF model, which are actually, it cuts across the world regardless of what your level of income actually is. Hearing from them that they are sitting down with the WHO, as I said, and the governments and policymakers, and how can we make it accessible? I mean, that's really so nice to hear, because as we said, after being a beneficiary for 20 years, we also want to move on to the next phase. How can we be partners in caring for the children? Attorney Joni?
Thank you. Well, I joined Dr. Padilla in thanking Sanofi because they've been our partners for...
Some of you just take a photo, right? It's okay. Okay, some of you have presented about the number one related to the policy. Yeah, I do agree. We do agree with that. Every rare diseases, right? We have to have a clear policy on this. Yeah, I know some of you may have a repeated redundancy demand on their policy, but we need to have policy for us to work on, and we have to establish strong policy for our region. It is not just
go to testing or accelerate in the middle income country. Thank you. Thank you.
As related to the issues of funding, that is really resonating to the government representatives here. But before I would like to comment on the funding, of course, I'd like to thank Group 1 for bravely really computing for the needs of the government.